Okay, dear friends, welcome to the first edition of this course on cardiovascular health in the dental office. Thank you very much for being with us. Thanks to the Spanish Society of Periodontology and, of course, to Dentaid for their sponsorship of this initiative, which is having success, both in Spanish and English editions. Of course, a special thanks to the speakers of these three webinars. They are great experts in their fields who will transmit us in a very practical way. In this second session, we will develop the prevention of cardiovascular complications in the dental office, mainly arterial hypertension and atrial fibrillation. In addition, we will have a very interesting discussion between a cardiologist and a periodontist on how to prevent these complications in a practical way. For this purpose, we have Dr. David Vivas, who is a doctor in medicine, a specialist in cardiology with a master's degree in clinical unit management, and actually is developing his work at Carlos Clinical Hospital. On the other hand, Dr. Eduardo Montero has a degree in dentistry, a master's degree in dental science, and a master's degree in periodontics, both from the Complutense University of Madrid, and he has the European Board on Periodontics from the European Federation of Periodontology. So, thank you very much, both of you, and please go ahead, Dr. Vivas, very well.
Thank you so much, Miguel, for your kind presentation and your kind invitation. Hi, everybody. As Dr. Okay, so thank you very much, everybody. In my lecture, I will try to explain the periodontal pathologies and cardiovascular disease and preventing complications in your consult. Okay, I like to introduce the first pathology, which is the arterial hypertension. Okay, which is so prevalent in our country and in the European countries. This is a very famous study here in Spain for the prevalence of arterial hypertension, and as you see in this slide, 1/3 of the population in Spain and also in the European countries has hypertension, okay? And this risk factor increases with the age, okay? The older population are, the more prevalent hypertension is. So more than 65 years in our population, hypertension increase up to 60% of people. So I think that one of the first things that you need to know about high arterial hypertension is how to manage, how to measure the blood pressure. This is an important thing because I'm all my colleagues from the Spanish Periodontal Society think that it's very important to learn how to measure arterial blood pressure and arterial hypertension in your consultants. So this is a few advices for you, very, very simple. As you see in the picture, in the figure, the patient should be seated comfortably in a quiet environment for 5 minutes before beginning the blood pressure measurement. We recommend at least 2 or 3 measurements with 1-2 minutes apart, and additional measurements only if the first 2 reading differs more than 10 or 20 millimeters high. It's very important to use a standard bladder cuff, more or less than 12-13 centimeters wide and 35 centimeters long for most patients, but have larger and smaller cutoff available for larger and thinner arms, obviously, respectively. It's important when using auscultatory methods, use that we in cardiology call the 1 and 5 Korotkov sound. It's very simple. If you increase the blood pressure with the device, okay, you heard one first sound. Okay, the first sound is called the Korotkov one. This is the high blood pressure, or called the systolic blood pressure. Okay, if you decrease slowly, this sound disappear. When the sound disappear, we call the phase 5 of Korotkov sound, and this is the low high pressure, or called technically the diastolic blood pressure. Okay. The last thing that is important in this slide is to remember that not only is important the blood pressure, but also the heart rate. Okay, and you can diagnosis, as we have in the second part of the presentation, you can diagnose with the measure of blood pressure one kind of arrhythmia. Okay, the atrial fibrillation, and the pulse palpation is very simple, and we could use to diagnosis these frequent cardiovascular problems. Okay, so which is arterial hypertension? How can we define arterial hypertension? Okay, arterial hypertension is a number. It's a number that higher of 140 in the systolic, in the high, and more or high than 90 in the diastolic or the low. Okay, this is very important because hypertensive patients are graduated for each values of blood pressure. For example, grade 1 hypertension is between 140 or 159 for high pressure and 9 to 99 for diastolic high pressure. Okay, the normal or the optimal high blood pressure we classify with values of 120 for the high or less, and less than 80 for the diastolic, for the low. Okay, this is important to know in the medical general culture. Why is important the blood pressure? Why is important arterial hypertension? Because arterial hypertension is only a number, but it's not only a number, of course, because this is one of the main important cardiovascular risk factors. So we know in cardiology that higher hypertensive patient, more frequent the patient could develop cardiovascular outcomes. Okay, this is important to know that the older patients we have in our consultants, more or less than 65 years old or higher, okay, is more important to control the systolic blood pressure. I mean the high, okay, because this is a better predictor of cardiovascular events. Okay, and not only is important hypertension. Arterial hypertension usually is associated to other risk factors. Example given: smoking, diabetes, hyperlipemia, etc. Okay, what's the problem? That when you add one or more than one risk factor to the hypertension, the patient have a synergistic effect. I mean, the metabolic risk is higher. Not only is important arterial hypertension, but also the global cardiovascular risk assessment of the patient. Okay, and it is very important because in the clinical practice we use a score system which predicts the 10-year cardiovascular mortality. Okay, you with 2 or 3 or more or less factors, very simple to know, you can predict the probability of the patient dying in the next 10 years. This is an example of the tables that we use in the clinical practice. It's very simple. There are a lot of numbers, but it's very simple to know. I like to share an example because if the patient has age, for example, of 60, if is woman or man, or if smoker or non-smoker, if we know the systolic blood pressure and the cholesterol total levels, we have a number in colors, green, yellow, orange, or red. It depends on the risk, okay? The lower is green, the higher is red. And we know a percent of a score at the top of the table, which we predict the risk less than 1 or 10 or more than 15% risk that the patient die in the next 10 years with only these synergic risk cardiovascular factors. In this table, I try to summarize the score system, and it's very simple because the colors are the same: yellow, orange, red, and dark red. And you can see that with the stage of hypertension, the stage is the patient rating high normal, grade 1, grade 2, or grade 3. Depends on the systolic blood pressure and the number, okay, at the levels of the hypertensive, is or not associated with one or more than one risk factors. Not only the risk factor, but also the established cardiovascular disease. I mean, the patient could have a myocardial infarction, a stroke, and this patient have a very high risk of repeat the cardiovascular event. And it's very important to have a very strict control of the arterial hypertension. Okay. You can ask about what are the clinical manifestations of the arterial hypertension, and more than 95% of patients are asymptomatic, which is the most frequent clinical manifestation, no clinical manifestation, okay? Hypertensive could appear in an acute way with an urgent or an emergency. The difference is between in urgent, the problem is the number, and in emergency, the problem is the number. I mean, the blood pressure is very high, but it develops an organ damage. For example, a stroke, for example, an acute kidney injury, or an acute cardiovascular failure. It's more common in our population to have a chronic hypertension. Chronic hypertension, the more frequent is, which is called the primary chronic hypertension, 90-95% of patients, but 5 or less than 5% of patients have a cause, an etiology, secondary arterial hypertension, more frequent, a problem in the kidneys, or a problem, genetic disorder or hereditary disorder, okay? Which is important, arterial hypertension, because hypertension mediated organ damage. Organ damage is the main problem of high blood pressure. This is organ damage could cause in every organ of the body, but the more frequent are the next. First one, the heart. Okay, in the heart, this is a normal heart on the left, and on the right, this is the hypertensive heart, the cardiac hypertensive heart. It's supposed to produce a left ventricular hypertrophy. I mean, the muscle, the heart is a muscle, and when you need to increase the blood pressure, the muscle works a lot of more. And when it happens, the heart in a chronic way fails. If the heart fails, you have a cardiac failure and a cardiac ischemic disease, okay? The second, in frequency, the second organs damage is the brain, okay? The nervous system, and most frequent, the stroke. The stroke, you have a intracranial bleeding, such as TCCT, an example, which patient, this is a disabled disease, which it not only cause death, but also a disabled, very important for our patients. Not only the heart is affected, but also the arterial, the peripheral arteries are affected with the with the hypertension, the kidney damage is very important because the diabetes and hypertension are more frequent causes of kidney coronary disease, and this is very important and very disability for the patient. And the last one, the eye. In this case, the hypertensive retinopathy is one of the most important cause of blindness in the population, and hypertension, bad control hypertension, could cause this important problem. Okay, so for us, it's very important to keep the blood pressure in the normal way. How can manage arterial hypertension in our clinical practice? Well, the treatment reflects these three points. The first one, and the more important, is lifestyle changes. Second way, pharmacological treatment, and new therapies, new devices that are in development nowadays. So, how can manage arterial hypertension? It depends. That I said before, for two things. The first one, obviously, the level of blood pressure, and the second one, the synergic risk cardiovascular factors. It's not the same a patient with 140 and 95 grade 1 hypertension with no other risk factor than the patient that with established cardiovascular disease, diabetes, organs damage, injury, etc., etc., etc. But in every moment, the first step is lifestyle advice. This is very, very, very important. Okay, and lifestyle changes. What does it consist? Well, very, very simple. Is to pass from the top figure to the bottom figure on the right. No, this is not very, very, very easy for us to change this one, but well, with these five advices, we try at least. So one of the first things that we recommend is the salt restriction to less than 5 grams per day. It's recommended to restrict alcohol consumption, to avoid binge drinking, the smoking cessation, and the increase of consumption of vegetable, fresh fruits, fish, nuts, and unsaturated fatty acids, mainly the olive oil, the extra virgin olive oil, okay? And allow consumption of red meat and consumption of low-fat dairy products are recommended. And regular aerobic exercise, at least 30 minutes of moderate dynamic exercise, walking, biking, spinning, swimming, etc. 5 to 7 days per week is recommended. For the audience that I mean that is not from Spain, this is what Mediterranean diet means, okay? Or the Mediterranean diet is what we try to apply in our patients, and this is scientific evidence to this is the better for the cardiovascular patients, okay? In one slide, I like to summarize the pharmacological treatment. Only to know the names, if some patient told you what are the pills that they are medicated, okay? It's important to know that beta blockers or angiotensin receptor blockers are the most frequent treatment, pharmacological treatment in this patient, and they are very, very used in our clinical practice, okay? And there are no contraindications to have some dental procedures, okay? So this is my first part of the lecture, of the presentation. I like to focus in the second part in the one of the most frequent arrhythmic disorders in clinical practice, which is called the atrial fibrillation. The atrial fibrillation is defined by arrhythmia. Arrhythmia is a rhythmic disorder. Okay, this is in Spanish, but I like kindly to use. This is a normal heart. Okay, the impulse of the heart. You know, the heart in order to contract, in order to expulse and impulse the blood needs to be an electrical pulse. The electrical pulse goes from the top of the atrial to the top or to the bottom of the ventricle. Okay, in atrial fibrillation, the problem is that there are a lot of impulse. Okay, a lot of electrical impulse, which in clinical practice is not effective, if not efficient, the contractions, and the blood remains in the atria, and the probability of form clots is very, very, very high. Okay. So what are the etiologies or the causes of the atrial fibrillation? It's very, very related to arterial hypertension. Okay, so the synergic metabolic risk factors in a cardiovascular patients have in common with arrhythmias, disorders, with chronic ischemic disease, with cardiac failure, etc. Diabetes, arterial hypertension, obesity, valvular heart disorders. On the left, you have a mitral valve, normal mitral valve, and on the right, you have a figure with a mitral valve stenosis. Okay, this is very common in diseases such as the rheumatic disorders, rheumatic heart disease. Okay, it's very common to develop atrial fibrillation. This patient is a Netter figure, a classic Netter figure from the patient with an angina and a myocardial acute myocardial infarction. This is cause of the atrial fibrillation as well. Elderly is cause of atrial fibrillation. Drinking is cause of atrial fibrillation, and genetic or hereditary disorders could cause atrial fibrillation. Okay. So one thing that hypertension and atrial fibrillation have in common is that they are more frequent with the age. As you know, this is one study from Rotterdam and the Atrial study and European study, that patients frequent of atrial fibrillation increases with age, and increasing with age, increasing with age in men and women. Okay, and is more frequent in women, in elderly women than in elderly men. What are the clinical characteristics of atrial fibrillation? The same as the arterial hypertension, is more frequent that atrial fibrillation succeed in patients asymptomatic, and this is a very, very important problem, because if we don't have a pulse palpation in our clinical practice, we couldn't avoid the complications of atrial fibrillation. The more clinical characteristics are palpitations. Patient with tachycardia feels palpitation, dyspnea, shortness of breath, dizziness of syncope, or neurological symptoms. The last one is the most important, because it's one of the main causes of stroke. Okay, and if you have in this figure the clots inside of the heart, goes to the aorta artery and the carotid artery to the nervous system. Okay, and cause the block of the flux of neurological system, and cause the stroke or the intracranial bleeding. That is one of the disability of this arrhythmia, one of the main consequences. Okay, so how to manage, how to diagnose in our clinical practice? Okay, most frequent to diagnosis in our consulta. This is our consulta. There are two volunteers for the picture, two fellows of our institute, Cardiovascular Institute in San Carlos University Hospital here in Madrid. Okay, we use the ECG, the electrocardiogram, and the echocardiogram to diagnose the atrial fibrillation and its complications. Okay, this is an example of an ECG with a patient with atrial fibrillation. As you know, these are the irregular arrhythmia call colloquially, okay? And nowadays, the smart phones and in this kind, the Apple Watch, for example, have this is an aid that could help us to diagnose, to detect patients with arrhythmic disorders. And there are some evidence in high-level medical journals, such as New England, Lancet, etc., with evidence to prevent or to previously diagnose before the clot or before the complications atrial fibrillation in this kind of patient could be helpful in the future. Okay. So what about the treatment of atrial fibrillation? Okay, in the treatment we focus on three steps or three ways. Okay, the rhythm control with antiarrhythmic drugs. These are the most frequent in order to sound you, amiodarone, flecainide, propafenone. A lot of it's not uncommon to have patients that not respond to antiarrhythmic drugs and need to have an electrical cardioversion, such as at the bottom right of the slide, an example with not a patient, logically, that we have an electrical cardioversion. Okay. The second way is the rate control with beta blockers, which are drugs used as well for the control of arterial hypertension, atenolol, metoprolol, carvedilol, calcium antagonists, or digoxin. And the most important is the third step, the last but not the least, the antithrombotic treatment. As you know, I said before, the clot, the thrombus, is the most important consequence of atrial fibrillation. We need to use antithrombotic, anticoagulant treatment in order to avoid the thrombus. So, how can how can classify patients for no risk, low risk, or high risk to form the clot, the thrombus? The high thrombotic risk is called with this scale called Chatzbask, that which is formed with these 7 items: congestive failure, hypertension, age more than 75 years old, diabetes, stroke, vasculopathy, age between 75 to 74, and sex, in this case, female. Age more than 75 and a stroke scored with 2. The rest of items scored with 1 point. If the patient have 2 or more than 2 points, is a high risk of thrombotic event, so we need to use an anticoagulant to avoid the stroke. Okay, to avoid the stroke, we have a lot of anticoagulants. These are the more famous. In Spain, we use the vitamin K antagonist called acenocumarol syndrome. In the rest of countries, you use the aldocumar or warfarin. Okay. There are in the last years a lot of oral direct anticoagulants or new anticoagulants that avoids the control of INR or the parameters of the anticoagulation, which are dabigatran, rivaroxaban, apixaban, and edoxaban. Okay, I try to finish with these 2 last slides. The first one is that from the Spanish Cardiovascular Society with other scientific societies, included, of course, the Spanish Periodontal Society. We have a consensus document with the management of perioperative and periprocedural management of antithrombotic therapy. It's in Spanish and also in English, and it's for free in PubMed. Okay, and I recommend it to this lecture. Okay, in which we recommend how to manage to suspend or to keep from one or another procedure the anticoagulant treatment. Not only is the consensus document, it exists one app, okay, for Apple, Android, and web Internet Explorer, okay, which is free to download. now is in Spanish, and in the next weeks we have this apply for English as well. So don't worry if you don't have to speak or to understand the Spanish, the Spanish language, that is in the next weeks in English as well. Okay. So for me, this is all with my chat. Thank you very much for your attendance, and if you have any doubt or something to ask, I'm ready to answer. Thank you very much.
Okay. Thank you very much, Dr. Vivas, for your brilliant and interesting presentation on the prevention of these frequent and important cardiovascular diseases like arterial hypertension and atrial fibrillation. Very, very important for the patients and for understanding the fight against them. And now, the second part, Dr. David Vivas and Eduardo Montero are going to develop an interesting discussion on how to avoid cardiovascular complications in always, of course, from the practical aspect. So, thank you very much, Doctor. Please proceed when you want.
So, good afternoon, everybody. First of all, I would like to thank David Vivas, Dr. Vivas, for the awesome lecture that he just gave to us. It was very clear and extremely interesting. I would say that for the entire dental team, including both dentists and dental hygienists. So thank you very much for this lecture. And I also would like to thank to the Spanish Society of Periodontology, to Dentaid, and particularly to Professor Miguel Carasol for inviting me to participate in this series of webinars that I think that are extremely interesting for our profession. And before, or in order to start the discussion, I would like to ask a couple of questions, Dr. Vivas, regarding what I would say is a hot topic nowadays in periodontology or in dentistry, and is related with the fact if dentists should somehow be involved in the screening of certain previously undiagnosed conditions, such as maybe arterial hypertension. You mentioned that there are an important percentage of the population that suffer arterial hypertension, but they are not aware. And at the same time, maybe we can do something regarding atrial fibrillation. So do you think that dentists should regularly take or register the blood pressure of patients in the dental office, for example?
Thanks, Eduardo, for your question. I'm totally agree to measure arterial hypertension in all the patients, but the patient who can have more risk than the average population. I mean, elderly people, if there are no diagnosis for hypertension, I think that it's very cheap and very efficient to measure blood pressure in the dentist consultant. Okay, not only blood pressure but a pulse palpation. It's very, very simple to put your hand or your fingers, okay, in the patient's wrist, okay, and measure and palpate the pulse, because there are a lot of patients in not in the cardiovascular or cardiologist consultant, but in the GP. In the GP, there's a lot of patient diagnosis from atrial fibrillation only to pulse palpation. Okay, it's very, very, very simple, and this is an arrhythmia with a lot of disability. Okay, stroke is catastrophic disability for us, for patient, okay, for the system, for the national health system, and it's very, very simple with a measure of blood pressure and a pulse palpation to diagnosis in our consultants, in the dentist consultants, in the GP consultants, in the overall population, okay, to have this very, very simple measure.
I was asking because indeed in the Spanish Society of Periodontology we just finished a study evaluating the possibility of identifying previously undiagnosed diabetes in the dental setting that is close to be published. But Dr. Miguel Carasol is heavily working on the development of also a protocol to evaluate certain cardiovascular diseases that could be early identified. I wouldn't say diagnosed, but early identify or to identify subjects at risk in the dental setting. So I think that I completely agree that there are from this kind of collaborations there can be only benefits. It's the only possibility. So it's there's no harm for the patients if we register from time to time the blood pressure, particularly in certain patients under risk, or particularly even before certain procedures such as surgeries, because I think that this is crucial, and this is something that I would say is not so common to register the blood pressures of patients before surgical procedures. So I also would like to start from the beginning. I would like to know if what kind of questions do you think that dentists should ask patients with previous history of cardiovascular events in order to register an adequate medical history? What do you think? Which questions do you think?
For this is a win-win for cardiologists and odontologists. Okay, so it's very simple. I recommended to summarize in 2, 3, or a couple of questions for the patient to remark if the patient has a previous vascular disease, the cardiovascular risk factors, okay, hypertension, diabetes, hyperlipemia, smoking. Smoking is one of the main causes of periodontal diseases, okay, so we share in common a lot of, so, and it's very, very important to know the previous treatment of the patient, okay, because I have the feeling that when a patient goes to the dental consultant, at least in Spain, they don't have the importance to share with the dentist, okay, the drugs, the pills they take, okay. So in a GP or a cardiovascular consultant, the first thing the patient told us is, doctor, I have treated with the blah, 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 blah. But with the dentist, my feeling when I talk to you or your colleagues is that very important, no? To know that you need to keep my teeth okay, but what is the importance do I have to have an enalapril for to keep my blood pressure in range?
I agree, because yeah, it's true that patients sometimes they are the ones that they don't pay importance to the drugs that they are taking after suffering a cardiovascular event, and when we are asking to them, they don't know how to answer, or they don't know what exactly they are taking, or they are just tell you the blue pill. Maybe the blue pill is for another thing, or whatever, you know. So it's something that we need to develop also some kind of education to the patients also in order for them to be aware and more involved in their health, I would say, both from a systemic and particularly from a dental point of view. So particularly in these patients that we are maybe imagine patients that have just suffered a cardiovascular event such as an acute myocardial infarction or any other kind of event, or ictus or stroke, for example. What do you think? How long do you think that dentists should wait before starting to treat these patients? Do you think that it depends also on the procedure? What's your opinion?
Yeah, this is a very frequent question for you and for the patient when they come in the first visit after the cardiovascular event, stroke. The most important thing is that is the procedure an urgent or an emergency? Okay, because this is not the same dental procedure that, for example, an oncology surgery. I mean. So it's important to wait at least some weeks after the stroke or after the acute myocardial infarction, but it's more important to wait that patients finish their antithrombotic treatment, because one of the things that you can expect for safety to the periprocedural treatment in dental procedures is that the patient have a low bleeding risk and a low thrombotic risk, okay? So this is very important because patients have acute myocardial infarction and 2 or 3 months they could perform a dental procedure, but the patient has clopidogrel or warfarin treatment. It's very important to wait a lot of more in order to a safe and a better prognosis on the cardiovascular disease and on the dental procedure. Okay?
I would say that probably if you ask most of the dentists that they would like to ask to a cardiologist, most of the questions would be related with the management of these patients undergoing anticoagulants as drug therapy. And in this sense, in which situations do you think that it's necessary to evaluate or to register the, for example, the INR in the dental office?
Yeah, it's very important. The scientific work in the past few years are focused with our society and your society in consensus document to perform. If you don't mind, I will try to have an example for this topic, and this is very simple and easy to share and easy to explain. Imagine that you have a male 74 years old with hypertensive, hyperlipemia and coronary artery disease with an acute myocardial infarction, which is treated with percutaneous coronary interventions, and they have a treatment, antithrombotic treatment with 2 antiplatelets, aspirin, acetyl salicylic acid, and ticagrelor, okay, a very potent antiplatelet. I follow up with my consultant at 4 months after the myocardial infarction. The patient is doing well, is symptomatic, but he asked me a question, a very frequent question in colloquial language. He told me, I went to my dentist so as to treat my teeth. And this means in the dental procedure, 1 extraction, 1 obturation, and 1 dental cleaning, okay? So if we have the thrombotic risk and the bleeding risk, we can know how to proceed, okay? So in this patient, the thrombotic risk is related with the acute myocardial infarction, the ICP or the PCI, the percutaneous coronary intervention, and in the first 6 months after the acute myocardial infarction, the risk is red, the risk is high, okay? On the other hand, the bleeding risk for dental procedures, according to the consensus document, is low, okay? Is such as the hand plastic surgery, endoscopic procedures, or ophthalmology procedures as well. And if you go to the algorithm, how to manage is very, very simple. For antiplatelet treatment, we have to ask if this is an emergency surgery, no, okay. If you have the antiplatelet treatment for primary prevention, no, this is secondary prevention. The patient has myocardial infarction, yet. What are the thrombosis, the thrombotic risk? The thrombosis risk we have that is high or intermediate high, okay. If the patient is an intermediate or high thrombotic risk, we ask about the deferrable surgery. I mean, we can postpone the surgery in this case, maybe. I think that maybe. So, yes, sorry for the Spanish, we we should postpone, okay? But imagine that the patient is not postponed or the thrombotic risk is low. It's low because the myocardial infarction was at 3 years ago, okay? In this case, okay, the intermediate high thrombotic risk and non-deferral surgery, okay, we could ask about the bleeding risk. And the bleeding risk in dental procedure, you are very lucky for you, because this is for example, the oncology surgeons or neurovascular surgeons are in serious troubles for this. Okay, the bleeding risk is low, so you can manage your patient. You can have your procedure with maintaining aspirin, okay, in 100 milligrams per day, and the P2Y12 antagonist, which is the ticagrelor or clopidogrel or prasugrel. You can have the procedure, okay? This is very simple, but slightly complicated because you have to study the document, you have to keep in your consultant, but we need to simplify the decisions, okay? And to simplify the decision, we manage this APP, QXAAPP, okay? I mean, this is in Spanish, but don't worry, in the next few weeks you have in English and you can download from the Apple device or the Android device, okay, for free. This is an example in Spanish language, sorry for that, but I like to translate kindly, okay. The APP first asks you about which is the treatment. In this kind, you need to check aspirin and ticagrelor, okay, and to click continue. The APP asks you about the urgent of surgery. Click no. The intervention, the procedure, you need to select the procedure, in this case, odontology, okay, odontology and maxillofacial surgery, and you need to look about what are the procedures you need to do. Dental explorations or extraction, etc. So, for example, an obturation, okay? The bleeding risk on the bottom, right bottom of the slide is low, okay? The thrombotic risk is acute coronary syndrome, acute myocardial infarction, okay, and percutaneous coronary intervention less than 6 months because the patient comes to the consultant at 4 months, okay. So the thrombotic risk at the bottom is moderate, okay. The APP summarize the characteristics, the clinical characteristics of the patient. The drugs are aspirin and ticagrelor. The bleeding risk is low, the thrombotic risk is moderate, and to continue, to need to click about this patient. This patient is primary preparation is no, and from surgery, if you could guess the APP answer that the surgery should be postponed, but imagine that the deferrable risk is no, okay, and the APP have to keep aspirin and ticagrelor, okay, and to do surgery without any problems. This is the APP is very simple, okay. You don't know cardiology for to use. It's very simple, and I repeat, in the next few weeks you can download in English version, okay.
I think that this is an incredible tool, very helpful for dentists and for the entire dental team. And I would say that probably in Spain there has been a tendency. In the past, it was much more common to stop some of the anticoagulants therapy before performing dental procedures, but probably also related with the change of the drug prescription in these patients and other issues. Nowadays, it's not so common, but still there are a lot of patients that are taking antagonists of the K vitamin. So in these cases, it's important to particularly know which is the risk of bleeding of these patients under certain circumstances. For that purpose, we have this possibility to evaluate the INR in the office, and these kind of devices are not extremely expensive, and I would say affordable by a clinic, and probably worthy. But what's the threshold that you think that we need to consider, for example, for a surgical procedure, depending on the bleeding that we expect that is suitable before doing surgery?
Yeah, this is a very good question. For the audience, imagine that you don't have a dental procedure, but also a pacemaker implantation. Okay, that is a more aggressive procedure. Okay, with device implantation such as a defibrillator or pacemaker, we use INR less than 2. Okay, less than 2. I mean that kind procedures such as dental extraction, okay, 1 or 2 pieces, I think it could be possible to do without suspend the vitamin K antagonist. Okay, for more complicated procedures, I recommend to suspend the antagonist, the vitamin K antagonist, and maintain an INR less than 2. This is the most recommended. Okay. What is the problem, or not the problem? What's our advantage that nowadays is more frequent to find patients treated with the new anticoagulants. Okay, and the new anticoagulants are not necessary to control with the INR and with any parameter. So their biodisponibility in blood is very, very predictable, and this is a very, very advantage for us. For example, if I take apixaban or rivaroxaban, I know if I don't have any kidney problems, because these drugs eliminate by the kidney or by the liver with the warfarin, for example, I know that if I suspend the treatment 24 hours before the procedure, I needn't control the INR, and I very safe, go to the dental procedure without any other test. And this is very, very important and very comfortable for us, or for you in this case.
And also we have local tools that we can use also in order to control the blood. So yeah, as you said, there are a lot of procedures that there's some bleeding, but probably do not need for suspension of the drug therapy of these patients, because we are going to be able to control them easily. But I would say we will spend some time talking about the management of these patients and their anticoagulants. And I would say that the other field in which most of the dentists have more doubts regarding the management of their patients and raising questions to cardiologists is probably those cases in which we need for the antibiotic prophylaxis for endocarditis. And we are aware that each time this number of cases are less and less, because the guidelines are each time more strict. So I would like to ask you what the current situation, which patients need prophylaxis for the bacterial endocarditis in the dental setting, and for which procedures, I would say.
Very, very important question, okay, for the clinical practice. As you know, the criteria for antibiotic prophylaxis of infective endocarditis are very restricted nowadays. Okay, the guidelines changed a few years ago, and we have pointed only a few procedures, most odontological, okay, most dental, and with a few cardiovascular pathologies. Okay, let me share again the slide. Okay. As you know, in these two slides, I like to share the current clinical guidelines for the management of infected endocarditis and the prophylaxis management. On the left, you have the cardiac conditions at higher risk of infected endocarditis, okay, for which prophylaxis should be considered. It's not an obligation, it's a recommendation, okay? And as you know, compared to the cardiovascular diseases 10 years ago, they are very restricted only for patients with any prosthetic valve is important, mechanical, biological, transcatheter, or prosthetic material was used for cardiac valve repair, okay? Patients with a previous episode of infective endocarditis are patients with congenital heart disease, but only congenital heart disease with cyanotic problem. This is the most uncommon congenital heart disease, okay, or which are repaired with a prosthetic material in the first 6 months, okay. They are very restricted, nor mitral valve prolapse, nor aortic stenosis or mitral regurgitation. There are conditions which don't need the antibiotic prophylaxis, okay? And should be considered only for dental procedures, not only for more problems, and only in procedures requiring manipulation of the gingival or periapical region of the teeth or perforation of the oral mucosa, as you know better than me, okay? It's not recommended, for example, for anesthetic injections, treatment of superficial caries, removal of sutures, dental x-rays, of course, placement of adjustment of removal prosthodontic or orthodontic appliance. So they are very more restricted than years ago, okay? And what are the antibiotics that we use? Very simple. If the patient is not allergic to penicillin or ampicillin, we use amoxicillin or ampicillin, but amoxicillin 2 grains orally 1 hour before the procedure. This is the most frequent use. If the patient is allergic, clindamycin 600 milligrams orally 30-60 minutes before the procedure is enough.
Thank you very much for your answer. So, if I understood well, nowadays these cases are in need of antibiotic prophylaxis are basically those cases that already suffer in the past bacterial endocarditis, those cases that presented some kind of device in the valves of the heart, or those congenital cardio diseases, no, that are probably these patients are aware from since they are young that they suffer from any particular something's wrong with their hearts. Okay, so yeah, this reduces severely the number of situations that we are in need of these prophylaxis. That probably was in the past was considered that bacteremias could be a risk, particularly in these patients. But we know we have bacteremia for everything that we do, eating, brushing our teeth. So it's not. It's much more important to select those cases that are really in need to prevent this situation. So I would say that this is pretty much what we would like to cover today with you, Dr. Vivas, and it has been a pleasure to spend this hour with you. Yeah, I think that your lecture was very clear, as I said, and very helpful for the entire dental team. I see that Professor Carasoli is with us. So probably he would like to say something before closing the event.
Okay, thank you very much, Dr. Vivas and Dr. Montero, for clarifying to all of us how we can prevent complicated cardiovascular situations in the dental office. Today, we know that 9 of emergency situations that occur in the clinic can be prevented. So everything that discussed by doctors in the cardiovascular field is very, very important. Thank you very much. Finally, I would like to thank you all for your participation in this course, and we will see you next week in the third and last session. Thanks a lot, and be careful with the coronavirus, please. Be careful. Thank you.
Thank you. Thank you all.
Thanks to you all.